Welcome to study session 2, Urinary and Renal Dysfunction. Introduction. In this study session, we will discuss the common problems of the urinary system, such as those involving the urethra, bladder, and the kidneys. Urinary tract infections will be discussed in detail. The role of the nurse in preventing these problems will be emphasized. Learning outcomes. At the end of the study session, you should be able to 1. Define urinary incontinence. 2. Explain urinary retention. Urinary incontinence UI. Introduction. Urinary incontinence comes with significant psychological problems, including embarrassment, loss of self-esteem, and social isolation in the elderly. It decreases their ability to maintain an independent lifestyle, thereby promoting dependence on caregivers and institutionalization. It should be noted that UI affects people of all ages because PIC2, but is particularly common in elderly people. Definition of urinary incontinence. The International Continence Society defines urinary incontinence as complaints of involuntary or uncontrolled loss of urine. Helen Reader, 2010. It is not a normal consequence of aging, even though changes in the urinary system, which are associated with aging process, may place the elderly at risk for UI. The older multiparous women, young nulliparous women, especially during the high-impact vigorous activity, are also reported to experience UI. Risk factors for urinary incontinence: pregnancy, vaginal delivery, episiotomy, menopause, genitourinary surgery, pelvic muscle weakness, incompetent urethra due to trauma or sphincter relaxation, immobility, high-impact exercise, diabetes mellitus, stroke, age-related changes in the urinary tract, morbid obesity, cognitive disturbance, dementia, Parkinson's disease, medications, diuretics, sedatives, hypnotics, opioids, caregiver or toilet unavailable. Types of incontinence and clinical manifestations. The clinical manifestation of incontinence depends on the type of incontinence. Let us examine the different types of incontinence. Stress incontinence is the involuntary loss of urine and urethra as a result of a sudden increase in intra-abdominal pressure, sneezing, coughing, or changing position. It mostly affects women and can be as a result of obstetric injury, fistulas, extrinsic pelvic diseases, and so on. Urge continence is an involuntary loss of urine associated with urgency. The patient is aware of the need to void, but is unable to reach the toilet in time. Reflex incontinence is a loss of urine due to hyperreflexia or involuntary urethral relaxation in the absence of normal sensations, usually associated with voiding. This commonly occurs in paraplegic patients because they have no sensory awareness of the need to void. Overflow incontinence is an involuntary urine loss associated with over-distension of the bladder. The bladder cannot empty normally and becomes over-distended. Despite frequent urine loss, the bladder never empties. Diagnostic studies. The following assessment parameters are necessary to diagnose UI: refocused history, physical assessment, and a bladder log or voiding record whenever possible. Obtain information on the onset of urinary incontinence, factors that provoke urinary leakage, and associated conditions. The physical examination, assessment of general health and functional issues associated with urinary function, including mobility, dexterity, and cognitive function. A pelvic examination, Careful inspection of the perineal skin for signs of erosion or rashes related to urinary incontinence and existence of pelvic organ prolapse. Local innervations and pelvic floor muscle strength. A digital examination of the pelvic muscle to determine weakness or tension. Ask the client to keep a bladder log or voiding diary to document the timing of urinations, episodes of urinary leakage, and frequency of nocturnal for at least 1 to 7 days. A urinalysis to identify possible factors contributing to transient urinary incontinence, for example, urinary tract infections, diabetes mellitus. The post-void residual PVR volume is obtained by asking the patient to urinate. This is followed by catheterization within a relatively brief period, probably 10 to 20 minutes, or an ultrasound can be used to estimate the residual volume. Urodynamic testing in selected cases of UI may be required. Imaging studies for associated upper urinary tract involvement. Nursing management. Types of UI, causes and treatment. Stress incontinence. Sudden increase in intra-abdominal pressure causes involuntary passage of urine. Occur during coughing, laughing, sneezing, or physical exercises such as heavy lifting, exercising. Usually small leakage may not be daily. Causes commonly in women with related pelvic floor musculature due to delivery, multiple deliveries, instrumental vaginal delivery or multiple pregnancies, atrophy the female urethra during menopause, decreased estrogen. Treatment: Kegel exercise, weight loss if obese, cessation of smoking, topical estrogen, urethral inserts, patches or bladder neck supports, devices to correct underlying problem. Urge incontinence. Involuntary urination is preceded by warning of few seconds or minutes with periodic and frequent leakage. Causes: uncontrolled contraction or overactivity of the detrusor muscle, disorders of the C-ends, Alzheimer's disease, and bladder disorders, carcinoma in situ, interstitial cystitis. Treatment: biobehavioral interventions including bladder retraining with urge suppression, decrease in dietary irritants, bowel regularity, and pelvic floor muscle exercises. Nitrocholinergic drugs such as oxybutynin, tolterodine at bedtime, containment devices. Principles of nursing management of a patient with urinary incontinence. The guiding principles in managing patients are that first, the nurse must understand that incontinence is not an inevitable part of illness or aging. Secondly, it is often a reversible and treatable condition regardless of age. The nurse must recognize both the physical and the emotional problems associated with urinary incontinence, maintain patients' dignity, privacy, and feelings of self-worth. The following interventions are helpful. Lifestyle modifications. Encourage smoking cessation because smoking increases the risk of stress incontinence. Counsel about the relationship between constipation, urinary incontinence, and urinary retention. Weight reduction program. Aggressive management of constipation with adequate fluid intake, increased dietary fiber, light exercise, and judicious use of stool softeners. Weight reduction program. Teach the patient about consumption of an adequate volume of fluids and reduction or elimination of bladder irritants, especially caffeine and alcohol, from the diet. Scheduling voiding regimen. Maintains a regular flexible schedule of urination, usually 2 to 3 hours, while awake. Timed voiding, a fixed schedule of toileting, typically every 2 to 3 hours during working hours. Habits retaining, scheduled holding toileting with adjustments of voiding intervals, which may be longer or shorter based on the individual's voiding pattern. Prompted voiding, scheduled toileting that requires prompts to void from a caregiver, usually every 3 hours in conjunction with operant conditioning techniques, rewards for maintaining continence. Bladder retaining and urge suppression strategies, scheduled toileting with progressive intervals of voiding. It involves teaching of urge control strategies, relaxation and distractions techniques, self-monitoring, use of reinforcement and other strategies such as conscious contraction of pelvic floor muscles. Pelvic floor muscle rehabilitation. Pelvic floor muscle exercises. It involves gently tightening the same muscle used to stop flatus or the stream of urine for 5 to 10 seconds increment, followed by 10-second resting phases, repeated and maintained 2 to 3 times a day to at least 6 weeks. A long period is suggested for the elderly client to strengthen the pelvic floor muscles. Vaginal weight training or vaginal tone retention exercises. The exercises are similar to Kegel or pelvic floor exercises. Electrical stimulation. This involves application of low voltage electric current to sacral and pudenda efferent fibers through vaginal and or surface electrodes to inhibit bladder over activity and improve awareness, contractility and efficiency of pelvic muscle contraction. Anti-incontinence devices. Intraurethral occlusive device, urethral plug. These are latex or silicone single-use devices worn in the urethra to provide mechanical obstruction to prevent urine leakage. Remove for voiding. Other forms of occlusive devices are urine seal, an adhesive foam pads worn over urethral opening. Urethral insert, a small plug inserted into the urethra, usually removed before urination. Bladder neck support device, artificial urinary sphincter. Intravaginal support devices, pessaries. These devices support bladder neck, relieve minor pelvic organ prolapse, and change pressure transmission to the urethra. Penile compression device, mechanically fixed compression device applied to the penis to prevent urine flow or leakage via the urethra, must be released hardly for voiding. Containment devices. Suggest containment devices to manage existing urinary leakage. External collection devices. External catheter systems such as penile sheds direct urine into a drainage bag, most commonly used by men. Absorbent products, disposable pads and undergarment systems. For inpatient or those in long-term facilities, nursing management include offering the urinal or bedpan and assisting the patient to the bathroom every 2 to 3 hours or at scheduled times. Ensure toilet is accessible to patients. Provide adequate privacy to allow effective urine elimination. Urinary retention. Introduction. Urinary retention can occur in any post-operative patient, particularly in those who have undergone surgery on the perineal or anal regions that resulted in reflex spasms of the sphincters. Retention may be acute or chronic. Definition of urinary retention. Urinary retention can be defined as the inability to empty the bladder completely during attempts to void. Inability to empty the bladder despite micturition or the accumulation of urine in the bladder. It also describes partial or incomplete emptying of the bladder. It affects more men at age 60 due to prostate gland enlargement and in women with size to cell. In acute retention, the patient experiences total inability to pass urine through micturition. Chronic urinary retention describes a state of incomplete bladder emptying despite urination. Causes of urinary retention: urinary tract obstruction, nerve problems or disease of the spinal cord that interfere with signals between the brain and the bladder. Examples include events or conditions that can damage nerves and nerve pathways such as infection of the brain or spinal cord, stroke, accident that injures the brain or spinal cord, pelvic injury or trauma. Surgery, post-operative complications in perineal or anal region causing reflex spasm of the sphincters. Furthermore, during surgery and with administration of anesthesia and intravenous fluid to compensate for possible blood loss, this combination may result in a full bladder with impaired nerve function. Medication. Some medications cause urinary retention either by inhibiting contractility of the bladder or by increasing bladder outlet resistance. Some drugs used to treat allergies, muscle spasms, anxiety or depression may cause retention of urine. They include antihistamine, anticholinergic, sedatives, antispasmodics, anesthetic agents, particularly spinal anesthesia. Other causes of urinary retention may be as a consequence of diabetes, prostatic enlargement, urethral pathology, infection, tumor, calculus, trauma, pelvic injuries, pregnancy or neurologic disorders, cerebrovascular accident, spinal cord injury, multiple sclerosis. Pathophysiology of urinary retention. The pathophysiology of urinary retention is based on three major pathological mechanisms: increased urethral resistance, secondary to bladder outlet obstruction, as occur in bladder stone, prostate enlargement, infection, urethral stricture, and constipation, impaired bladder contractibility, loss of normal bladder sensory or motor innervations. Clinical manifestations. The following are the common manifestations of urinary retention: acute urinary retention, pain in the pelvis, increased abdominal pressure, inability to urinate, lack of urge to urinate. Chronic urinary retention, back pain, fever, painful urination, frequent urination, nocturia, hesitancy, difficulty starting to urinate, difficulty fully emptying the bladder. Nursing assessment and investigation. The nurse should elicit the following assessment data from a client with suspected urinary retention: time of last voiding and how much of urine was excreted. Assess if the patient experiences small but frequent voiding, any dribbling of urine. Note patient's complaints of pain or discomfort in the lower abdomen. Examine the pelvic area for full bladder, which appears swollen or rounded. Does percussion of the suprapubic region or elicit dullness? Does a post-void bladder ultrasound test reveal residual urine? Physical examination of the lower abdomen can be done to feel the distended bladder through percussion. Diagnostic test: urine sample for signs of infection, bladder scan, post-void residual urine, X-ray and computerized CI scan, X-ray to determine obstruction, CT scans, using multiple X-ray images to construct a better view of internal organs to diagnose stones or other causes of obstruction. Urodynamic test to measure the patient's ability to empty the bladder steadily and completely. Electromyography to measure the muscle activity in the urethral sphincter. Management principles. The management will be considered under two subheadings: medical management, nursing management. Medical management goals. The following goals are usually borne in mind to relax the muscle of the bladder and empty the bladder, prevent infection, and prevent further complications. Drugs: bethanyl chloride, prescribed to treat bladder muscle problems and to help the bladder muscle to squeeze better, thereby improving the ability to urinate. Neostigmine bromide, to improve muscle strength in patients with certain muscle disease, myasthenia gravis, thereby preventing the breakdown of acetylcholine, which is needed for normal muscle functions. Alpha receptor blockers such as alfuzosin. This relaxes the muscle at the neck of the bladder and reduces the obstruction of the flow of urine. Laxatives and enemas are suggested if retention is secondary to constipation. Catheterization. This is done to prevent overdistension of the bladder in acute urinary retention. It forms an initial treatment to relieve the immediate distress of a full bladder and prevent permanent bladder damage. If catheterization is to be used for long-term treatment, the indication for use will depend on the cause of urinary retention. It may be used for continuous bladder drainage. A suprapubic catheter may be necessary if the obstruction is in the urethra, which prevents urethral catheterization. For suprapubic catheterization, an opening is made through the skin over the pubic bone, where the catheter is placed directly into the bladder. This tube will provide temporary drainage until the situation can be managed. Nursing management. The goals of nursing management strategies in urinary retention are to prevent overdistension of the bladder, correct obstruction, and treat infection. Careful nursing assessment and appropriate nursing interventions can prevent complications. The nurse should explain why normal voiding is not occurring and monitor urine output closely. Nursing measures to encourage voiding: provide privacy, ensure an environment and a position conducive for voiding, assist the patient with the use of the bathroom rather than a bedpan. This provides a natural setting for the voiding and may stimulate the urge to void. If this is not effective, apply warm compresses on the perineum to relax the sphincters. Simple trigger techniques such as turning on the water faucet while the patient is trying to void, stroking the abdomen or inner thighs, or tapping above the public area. A combination of techniques may be necessary to initiate voiding. Study session summary. The International Continence Society defines urinary incontinence as complaint of involuntary or uncontrolled loss of urine. Urine retention can be defined as the inability to empty the bladder completely during attempts to void. The pathophysiology of urinary retention is based on the three major pathological mechanisms: increased urethral resistance, secondary to bladder outlet obstruction, as occur in bladder stone, prostate enlargement, infection, urethral stricture, and constipation, impaired bladder contractibility, loss of normal bladder sensory or motor innervations. End of study session 2. Thanks for listening.